Hey, thanks for joining me. Today I'm going to walk you through how to diagnose ribs, and then we're going to focus on treating exhalation dysfunctions. And you're going to learn it all in 15 minutes, so we'll jump in. Okay, some ground rules so that you can understand ribs forever. We're going to start with the bite mnemonic. And you have to learn this, love it, know it for life, because it will come back up on your future exams. So I'm talking spring of your first year. When you get to spring semester, they're going to bring back ribs into some of your exams. They'll let you know, like, hey, we're going to test you on ribs again, so better review that. So you just have to know it forever. So bite mnemonic, again, B-I-T-E, we're going to split the word down the middle. So we're going to focus on the B and the I. I stands for inhalation, B stands for bottom. So in inhalation dysfunctions, meaning the ribs like to inhale and they're stuck in inhalation. So that means the chest, you know when someone breathes in, you can feel it rise. So those ribs are rising, but maybe you're not feeling it go back down into exhalation. So if they're stuck up, you know that the bottom rib is what's holding it up. Just like I have this cup. If someone tells me to hold the cup up, I can't hold it like this. It can't be something from the top holding it up. The bottom is where I have to go to hold the cup up. And same thing with a rib. If there's ribs 2, 3, and 4 that are stuck up, I have to know that if it's an inhalation dysfunction because it's stuck up, the bottom rib is the one that's holding those ribs up. So 2, 3, and 4 are stuck up. That means that the bottom rib, or rib 4 of this group, is holding all those ribs up. Now the T and the E. So E stands for exhalation, T stands for top. So again, we'll take this pencil. If you're going to press a button, do you have to go from under or from top? You have to go from the top. So if I'm going to press something down, I'm going to be pushing from the top. And it's the same thing with ribs. With ribs 2, 3, and 4, let's say I feel that they are exhaled and then they're not coming back up to inhalation. So they're not rising like they should. So they're stuck down. So something is pressing it down. If it's ribs 2, 3, and 4, I know that because it's an exhalation dysfunction, knowing the bite mnemonic, the T goes with the E. So the top rib is what's pushing the other ribs down. Also memorize this, how most people know that you have floating ribs in the back that don't have cartilage that go all the way to your sternum. So they don't have any of it. Ribs 1 through 7 connect directly to the sternum. So here's 1, 2, 3, 4, 5, 6, 7. You see 7 has this line going, and then all the other ones feed into the 7th cartilage. So ribs 1 through 7 are your true ribs, and the way that I remember this, I don't know if it works for anyone else, but like a 7, to me, it just kind of looks like a T, except someone erased half of the T. So that's how I always remember that 1 through 7 are T for true. And then if I can remember that, and I remember 11 and 12 are floating, the ones in between have to be your false ribs, which are 8 through 10. I didn't bother explaining this chart because a lot of it is memorization, but it also helps if you just know where muscles attach to. Like the anterior and middle scalenes both attach to the first rib. So when they contract, they pull the first rib up, which is why we use them if someone has a first rib that's stuck in exhalation, because they'll pull that first rib up. Anyways, back to this chart, memorize it, know it for life. It'll be on this exam, future exams, and boards. I got this chart off of Dirty Med on YouTube, and he has a few mnemonics to help us memorize it. So for using the pec minor, which we know we use the pec minor if our key rib is 3, 4, or 5, and pec has 3 letters in it, so that's how you know if your key rib is 3, 4, or 5, that's associated with using the pec minor. Kind of a weak mnemonic, but maybe it works. He also says that rib 6 starts with S and serratus anterior starts with S, so that's how you can correlate 6, 7, and 8 with serratus anterior. Instead of that mnemonic, I like to think 6, 7, 8, use serrate. So that's how I remember it. You'll also see that I crossed off some stuff on his table because it wasn't what DCOM is teaching us. I actually forgot, there's one other thing you have to know. Really quickly, it's the motions of the ribs. So you're going to take ribs 1, 2, 3, 4, and 5. Those are all your pump handles. So they pump up. If you were able to pick the rib up from the anterior side and push it down, that's what it does when you breathe. You breathe in, it pumps up, and pumps back down when you breathe out. And that's for 1 through 5. And so 6, 7, 8, 9, and 10. They're all your bucket handles. So imagine like you're gonna pick up a bucket if the bucket handle is on its side, you're going to pick it up, and that's what it does when you breathe in, and then you exhale and it comes back down. I also like to think of it as like a chicken wing, so it goes up and down. Lastly, your calipers. I still am kind of confused on what a caliper is, but I guess it helps measure stuff, and it kind of looks like this. So if, I'll use my finger as the other rib. If these are your ribs, they go backwards. So when you breathe in, they go more posterior and lateral. And then you breathe out, and they come more anterior and medial. So imagine taking scissors. So this is what 11 and 12 do. They go posterior and lateral, and then anterior and medial. So now let's talk about how to examine your patient. So for the first one, you're going to have your patient lay down, they're looking at the ceiling, they're laying on their back, and you are going to feel their clavicle and just go behind it, right near the neck, and you should feel something hard. And that's the first rib. So you're going to feel, and you can do this with me, you're going to feel the first rib, you should feel it rise. It's a pump handle, so it should get bigger in the front. So it rises when they breathe in and goes down as they breathe out. Next would be ribs 2, 3, 4, and 5. And a lot of times you don't want to just put your hand on someone, especially if they're female, they have a lot of breast tissue. So you go close to the sternum. So here's my sternum. And what I'm gonna do is kind of karate chop them. So I have my pinky feeling all this. So I'm gonna go close to the cartilage area, and I'm gonna feel that, so that you can go in between the breasts and it won't do anything. Your patient will be fine. Let your patient know what you're doing. This is definitely a lab where you have to talk through everything so that they're not just like kind of startled by what you're doing. So you put your hand here, put your other hand here, and you're going to have them breathe in and out. Again, these are all pump handles, so you should be feeling them get bigger, going more anterior, and then going back as they breathe in and out. And then we're gonna do ribs 6, 7, 8, 9, and 10, which are going to be your bucket handles. Now the nipple line is usually where rib 5 is, where I guess it connects to the sternum. 6 through 10 are all bucket handles, or the chicken wings, where it goes out like this. So your patient's gonna get wider. So you're going to feel more out to the side. So if this is, your thumb would be in the front, and then your fingers kind of wrap around the back. And if you have a patient who has a little bit more breast tissue, you can have them lift that up so you can actually get under that breast tissue to fully examine all the ribs. So your thumb's in the front, and you're going to be more on the lateral portion of the patient. You don't want to be in the front because they're bucket handles. They're moving out here more. You're going to feel that movement here, not in the front. So on the lateral portion, and you should feel it expand when they breathe in and go back down as they breathe out. Lastly, calipers. So that's ribs 11 and 12. And what you're gonna do is you're just gonna reach around the back. So your patient can still be looking up at the ceiling, laying on their back. You're just gonna put one hand, slide back over here, the other hand over here, and you're gonna monitor. And I'm gonna stand up so you can see. So here is my caliper, and so when I breathe in, what it's gonna do is it's gonna go more back, more posterior. So it's gonna go, so it goes more posterior and lateral as I breathe in, breathe out, and it goes more anterior and medial. Let's test your knowledge. So rib 3, what kind of movement does it have? Pause the video. I'm gonna say it. It has a pump handle motion, so it goes out like this. So you're increasing your AP diameter, your anterior to posterior diameter when you breathe in. Rib 7, what kind of motion does it have? It has a bucket handle motion, so it's gonna increase the width as it goes out when you inhale and back down when you exhale. 12, what kind of motion does it have? It's a caliper, so it's gonna go out like this and in like this. If I find that ribs 6, 7, and 8 on the right are stuck down, is this an inhalation or exhalation dysfunction? It's an exhalation dysfunction because they're stuck down. So the key rib is going to be the top rib that's pushing everything down into exhalation. So that would be rib 6, because 6, 7, and 8 are all being pushed down by rib 6. And if rib 6 is pushing everything down and it moved down, that means the space between ribs 5 and 6 is going to be increased, because rib 6 moved down and it's pushing the other ribs down. So you'll be able to feel a wider gap in between ribs 5 and 6. So now we're gonna treat rib 1. So here's my imaginary patient, and on the right side, when they breathe in and they breathe out, it rises and falls back down symmetrically. But on the left side, when they breathe in, I don't feel it rise up. But when they breathe out, I feel it go down. So when they breathed in, I didn't feel it rise. or go into inhalation. So they don't like inhalation, they're stuck in exhalation, which means they're stuck down. Okay, your patient has a left first rib that is exhaled, so it's stuck in exhalation. How are you going to position them? You're going to position them by taking their left hand and putting it on their forehead, and you're going to tell them to breathe in while trying to push their head forward, and then they breathe out and relax. Your job as the clinician is to put your hand closest to them. If you're standing on their left side, because that's the dysfunctional side, put your hand closest to them on their hand so that you're resisting when they try to push their head forward. So you have that hand pushing over here, and then this hand is going to slide underneath their back to find rib 1 up here. And when you find it, that angle of it, you're going to try to pull down on it when they breathe in. And so it's because it's like a seesaw. If I push, or I'd be pulling from this angle, but push or pull down, that makes it so the anterior part of the rib will come up. So it's like a seesaw. So your patient, remember, is stuck down in exhalation. So we want to try to bring the rib up. So that's why we go from under here and we try to pull that rib in the back down to bring the front part of the rib up. For rib 2, it's the exact same thing, except if rib 2 on the left is exhaled, I'm going to take my left hand, put it on my forehead, and I'm going to look away from the dysfunctional side. So the doctor is still going to be over here treating and have the patient look away from you about 30 degrees. And they're still going to push their head forward in inhalation and then relax during exhalation. And then you're still going to slide underneath their back and find rib 2. And you're going to be pulling down on that one while they inhale. And then when they exhale, you're just going to hold that barrier. You'll have them inhale again, and you're going to pull them into a new barrier, and so on. Now let's say that you have a patient who has a left-sided exhalation dysfunction, and you find that the key rib is rib 3. So you're going to treat rib 3 not like this, like rib 1, not like this, like rib 2, but you're going to have the hand, I guess technically you can have it here, but usually I just see people put it above their head. And you as a physician, you're going to push their elbow. So they're going to try to like high five you, and you're going to resist at the elbow. And they're going to try to high five you or really bring their elbow and their arm forward when they breathe in, and then they'll relax when they breathe out. So they don't do anything with the head this time. So you as the physician will do that with your hand closest to their elbow. Your other hand is going to slide underneath their back. You're going to find rib 3 because that's the one you're treating. You're going to go to the angle of the rib 3. And you're going to pull downwards towards their feet and also laterally. I think I forgot to say laterally before. Technically you have a force going caudally or going towards the feet, and also laterally going outwards. So you'd hold that just like you did with the others. Okay, now we have a patient who has a left-sided exhalation dysfunction, so the ribs are stuck down, and you find the key rib to be rib 6 that is stuck down and holding everything else down. So what you can do is have their arm like this, and to where their elbow is pointing towards the ceiling, since they're laying down looking at the ceiling. And you're, as the physician, going to just push on the elbow when they try to punch the elbow forward while they breathe in. And instead of finding one of the other ribs, you're going to find rib 6 in the back, and you're going to find the angle of that rib 6, and you're going to pull it down towards the patient's feet and laterally or to the side. Same thing, still do the same steps with muscle energy. Now we have an exhalation dysfunction on the left, and we find that the key rib is rib 9. So we're going to have the patient just put their left arm straight out while they're laying down on the table, supine. And they're going to try to adduct or bring, I can't do it because my desk is in the way, but basically doing this. Kind of like a snow angel when you add your arms back to your body. So you're going to try to resist that. So have your hand somewhere around here to where they cannot bring their arm closer to their body or closer to their hip. You're doing that motion while you resist, while they're inhaling, and you find rib 9, the angle of that rib, and you're going to pull down towards the feet and laterally or to the side. Next, we have a patient who has a left-sided exhalation dysfunction of their calipers, and you find that rib 11 is the key rib that's causing it all. So if the left 11th rib is the issue, you as the physician are going to stand on the right, and you're going to taco them towards you. So I should have a picture showing how to taco someone, bringing their shoulders, swooping them towards you, and their feet, swooping those them towards you. And what this does is it stretches your quadratus lumborum on the affected side. So if the left side is the issue, you're leaning them towards the right to stretch out that muscle. And then you're going to have them try to bring their hip to their ear. So it's hiking up towards their ear. But you're going to hold on to the top of the hip and resist that motion. And they do that while they breathe in.